Hello friends, I am Dr. Harsh Mathur from Om Netralaya, Varanasi, India, and this video contains an operative procedure meant for eye surgeons for education purposes. Viewer discretion is strongly recommended, and today we are going to discuss about this hard brown nucleus in an elderly lady and how to go about managing this case. So I'll be doing an MSICS. I generally prefer to do SICS over phaco in these hard cataracts because this SICS is friendly to the endothelium and we need to give a good result to our patients. So this is being done under subtenon anesthesia. 2 ml of lignocaine is injected in the subtenon space, and after waiting for 10 seconds a minimal cautery is done. This is a 1 to 1.5 mm of groove that I create to hold the sclera firmly, which helps me perform all the maneuvers easily. So now holding the groove, it's time to create the main incision. I need at least 7 to 8 mm of incision to bring out this huge nucleus out of the anterior chamber. A half thickness scleral groove is then created and the tunnel is initiated. So creating a good self-sealing tunnel is very important in these cases as the incision created is a bit large. Now the challenges in this case are we don't know the health of the zonules. The cataract is hard brown. The patient is diabetic, so I am expecting it to be leathery, and also the status of the cornea isn't very healthy. So keeping all these things in mind, I decided to go about doing SICS. The advantages of doing SICS is, as I am doing it temporally, I'll be neutralizing the against the rule astigmatism. Second, as I'll be not delivering much of energy in the eye, so it will be very friendly to the endothelium. All I need to do is coat the endothelium nicely while bringing out this huge nucleus, and for that I have made a sufficiently large enough main incision so that this nucleus comes out nicely. I want a generous large rhexis so that I can prolapse this nucleus out of the bag easily without putting much stress over the zonules. So I have a nice big rhexis. Minimum amount of hydrodissection should be done and the wound should be cut while going inside. It should be parallel to the limbus. Gentle alloquots of fluid is injected and the nucleus is mobile. With the help of dialer, gently wheeling it out of the bag. Now while prolapsing, we can see that the iris has shut down a bit. So once the vectis is beneath the lens, the visibility of iris becomes very less, so there are chances of getting it engaged and doing an iridodialysis. So care should be taken to keep constantly looking over the iris at 6 o'clock position and making sure that it's not engaged while pulling out the nucleus. Now once the huge nucleus is out, still the case is not over. We need to gently clean the bag, keeping in mind that the zonular health isn't very good, and also the posterior capsule needs to be watched carefully, because in these huge nuclei the capsule tends to become a bit thin and flimsy. And once the bag is clear, some fibrotic changes are there over the posterior capsule, but I am in no mood to touch those or polish the capsule. This is a hydrophilic IOL. The leading haptic is dialed in, and then the trailing haptic is gently dialed in the bag. And that's it. The case is done. So the take-home message is, in dealing with these hard nuclei, I feel SICS is far better than doing a phaco. Gives a very nice result, is very friendly to the patient, and you can give a very good result in this patient. So the wound is closed, the conjunctiva is reposited, there's no need to suture the wound, and that's it. The case is done. The patient was very happy. I hope you like this video. Do like and subscribe to my YouTube channel. Thanks for watching.